Welcome to the webinar. This is Valerie Cape at CMQCC. We welcome you today to learn about maternal sepsis. A little housekeeping to start as people are getting on. All lines have been muted on entry. Questions can be typed in the chat or Q&A box and will be addressed at the end of the webinar. The session is being recorded and will be accessible through the CMQCC YouTube channel tomorrow. The slides will also be available as a free download from the cmqcc.org website. And tomorrow you will receive a link to complete a very short 3-minute evaluation of the webinar, and we appreciate you taking the time to do that. And we will use the results to improve future educational webinars or content out of CMQCC. I'd like to, next slide please. I'd like to address our panelists today. Dr. Elliott Main is the CMQCC Medical Director and has chaired the California Pregnancy Associated Mortality Review Committee since its inception in 2006. He is currently Clinical Professor of OBGYN at Stanford University. He continues to be involved in several national initiatives through ACOG, the American Medical Association, and the multi-state AIM project, to name a few. He has helped identify the experts for and was an integral member of this task force in the development of the Maternal Sepsis Toolkit. Lori Olvera, DNP, is a perinatal nurse educator at Sutter Medical Center. She has been involved with several hospital systems to implement maternal sepsis protocols and worked as a co-lead on the task force for this toolkit. Her doctoral work centered around implementing standard work and interprofessional education for early recognition and management of maternal sepsis, which was published in 2016 Nursing for Women's Health. Lori has collaborated with the CDC, the Surviving Sepsis Campaign, the Society of Critical Care Medicine, the ANA, and the Sepsis Alliance to produce webinars on maternal sepsis. Christa Sakowski, MSNRN, is a clinical lead at CMQCC. She was an active member on the task force in the development of this toolkit. Christa has experience implementing CMQCC toolkits within a healthcare system and has been involved with CMQC's collaborative efforts since 2011. In her role as clinical lead, she works directly with hospital teams, mentors, nurses, mentors physicians, and the entire CMQCC staff to assess and improve care delivery in the state of California. She is also our huddles expert for the hands-on understanding of labor and delivery modules. Christa engages with the rest of the country as the California nurse representative for the Alliance for Innovation on Maternal Health, AIM, and serves as a resource for the use of CMQCC toolkits. We are also grateful for Dr. Ron Gibbs and his work on preparing for this webinar and on the toolkit, and recognize that he could not be with us today. Next slide, please. As you can see, the task force was very multidisciplinary, from OBs, maternal fetal medicine specialists, nurses, infectious disease, midwives, pharmacology, and emergency medicine, all contributing their expertise in their development of the toolkit. Next slide, please. The toolkit is organized with let me tell you about the learning objectives. To know the importance of maternal sepsis on morbidity and mortality, to understand the two-step method for screening and diagnosis, to describe the pregnancy-related differences in vital signs and lab values, to describe the treatment recommendations for maternal sepsis, and to identify steps to begin implementation on your unit. Next slide. The toolkit is organized with an introduction and broken down into 5 parts, which you can see on your screen at this time. And there's also a separate educational slide set and appendices. With that background, next slide, I turn the time over to Christa Sakowski to start the introduction. Christa?
Thank you so much, Valerie. So my job right now is to tell you why we're here and why sepsis. Sepsis occurs in about 0.04% of deliveries, and it's a leading cause of maternal death. Most cases, approximately 63% of maternal death from sepsis, are likely to have been preventable. And for each maternal sepsis, there are 50 women who experience life-threatening morbidity from sepsis. Next slide. One more. So this data from the CDC shows that infection is the leading cause in pregnancy-related mortality, confirming the need to focus on how we diagnose and treat sepsis within our population. Next slide. The leading causes of maternal sepsis through the antepartum period are septic abortion, chorioamnionitis and intraamniotic infection, pneumonia, influenza, pyelonephritis, and appendicitis. The intrapartum causes are chorioamnionitis, enterometritis, pneumonia, influenza, pyelonephritis, wound infections, and necrotizing fasciitis. Post-discharge causes are pneumonia and influenza, pyelonephritis, wound infection, and necrotizing fasciitis, mastitis, and cholecystitis. Next slide. The key clinical pearl that you'll hear over and over again is that prompt recognition and rapid treatment of maternal sepsis improves outcomes. The actions outlined in the toolkit are consistent with what we've found for other preventable causes of maternal morbidity and mortality. Next slide. Diagnosis of sepsis in pregnancy may be difficult because physiological changes of pregnancy may mimic the signs of sepsis. These include increased heart rate, decreased blood pressure, increased white blood cell count, and increased lactic acid levels in labor. This has made the criteria for diagnosing sepsis in non-pregnant adults different than pregnant adults, and that's why other systems that have existed in the past have not worked very well for pregnant women. Pregnant women are at increased risk for severe outcomes in some infections, such as influenza. Next slide. Previous definitions, including the 2016 Surviving Sepsis Guideline, define sepsis as a life-threatening organ dysfunction caused by a dysregulated host response to infection. It also defines septic shock as a subset of sepsis with underlying circulatory and cellular metabolism abnormalities that are profound enough to substantially increase mortality. Next slide. Historically, severe sepsis was defined as sepsis plus end organ dysfunction. The new definition of sepsis focuses on end organ dysfunction. The term severe sepsis is no longer recommended. And now I'm going to turn it over to Dr. Main to review the screening and diagnosis of sepsis.
Thank you, Christa. As you can imagine, the first and most important piece that we have to work on is how to screen for sepsis, how not to overcall or undercall. Next slide. To approach this, we developed a two-step approach for the diagnosis of sepsis during pregnancy and postpartum. We wanted first to do a simple screening step limited to vital signs, adjusted for pregnancy, underscore adjusted for pregnancy, including the most recent white blood cell count. That could be up to within 24 hours, i.e. the admission one. The second diagnosis step uses laboratory evaluation for end organ injury, again, with laboratory values adjusted for pregnancy where needed. The utility of lactic acid will be discussed in detail as it is debated, particularly because of potential rises during late labor and second stage. Next slide. We strive to achieve a balance between not overcalling too many sepsis cases and not missing appropriate treatment for infection. So our aim is to reduce false positives, which would involve alarm fatigue, and to reduce false negatives, which means avoiding missing cases. So our approach was based on clinical practice data sets from 3 hospital systems in California with adjustment for the physiological changes of pregnancy. So this is real world data, and we're looking at the experience that's been obtained in a prospective manner. So this features a 2-step approach, a screening test basically like Muse, followed by a confirmatory step. Next slide. The pregnancy-adjusted vital signs are shown here. They were developed from Large data sets illustrating 2 standard deviations from the mean, which identifies 38.1, a heart rate of 107, a respiratory rate of 24. In assuming a normal distribution, patients meeting these thresholds for each criteria would only occur 2.5% of the time. We rounded these off to 38 and 110 to make it easier for clinical use. Next slide. So this is the evaluation flow chart that we're going to go through in a stepwise manner momentarily. Next slide shows the first step, which is the sepsis screen preceded by a concern for infection or suspected infection, or just basically a vital sign WV screening as in a Muse setting. So again, a oral temp over 38, a heart rate over 110, a respiratory rate over 24, or a white cell count over 15. You are positive if any 2 of these are met. Now the next step is a critical one. If you suspect infection and you have a positive screen, you start antibiotics. This is classically the case for chorioamnionitis. Start antibiotics and you give some fluid, 1 to 2 liters of fluid. You increase monitoring and surveillance. And importantly, you move to do the confirmatory step, the confirmation step for sepsis itself. The side note on the right in pink is that if you do have a mean arterial pressure of under 65, again, this is adjusted for pregnancy, not just under 70, mean arterial pressure under 65 that is persistent after fluid loading in the setting of infection, that directly defines septic shock. So it's do not pass go, go directly to septic shock. Next slide. The tests to evaluate end organ injury are the common ones that we're all familiar with. CBC, coagulation status, comprehensive metabolic panel, a Chem 12 or its equivalent in your facility, and a venous lactic acid. We also are looking for bedside assessment, urinary output, pulse oximetry, and mental status assessment. Mental status ends up being a critical evaluatory term for sepsis. Next slide. These are the criteria for which any of these measures of end organ injury would turn positive. A PaFiO2 of under 300. This implies the need for a blood gas. This is certainly a blood gas that's required for if the pulse oximetry is under 94, you should move toward a blood gas. Coagulation status, platelets under 100, etc. Bilirubin over 2, blood pressure evaluation is noted, and a creatinine over 1.2. Again, these are adjusted for the normal ranges in pregnancy. We'll talk about lactic acid in more detail, but we're looking for a value over 2 in the absence of labor. Labor has its own issues with lactic acid. Next slide. So now this is step 2. We've done our confirmation of sepsis, and it's confirmed as sepsis if any one of the above criteria is met. So you've gone through step 1, which is 2 of the vital signs or white cell, and now you're looking at step 2, which is any one of these laboratory values. So if any one of those is positive, that defines sepsis. If the MAP is below 65 with fluid loading and confirmation, that's septic shock. Moving around counterclockwise in the striped oval, if elevated lactic acid is the only value that's abnormal and the woman is labor, well, that's a status that is a bit confusing. It's probably not full sepsis yet, but you have to treat this as a very high-risk patient. We recommend that you give additional fluids, repeat the lactate, and have maintain close surveillance. The last category is if you've had a positive step 1, where you have infection plus a screen, but you have no sepsis confirmation, that's a group that does not have sepsis, but is at risk for sepsis and should also require close supervision and reevaluation. Next slide. Here's the performance of the 2-step system, looking first at OB vital sign screen and then at sepsis. So the screen positive in data from Dignity Health and Sutter Health over almost 15,000 patients was 1.3%. The total with end organ injury was 33 or 16.5% of screen positives, or 2 per 1,000 of all screened. That actually is quite consistent with other large studies looking at the rate of sepsis in the obstetric population being 1 to 3 per 1,000. So the sensitivity is 97%, and the specificity is 99%. So this gets us away from a lot of the false positives and a lot of the false negatives that we've all been worried about at the beginning. Next slide.
Elliott, I'd like to make a little notation on that slide where it showed the calculation. The parentheses are in the wrong order. We'll correct that before we post the slides. And it is correct in the toolkit, just as a notation for people.
Okay. So the advantage of the two-step approach is that you have fewer missed cases, which is most important, but you also have fewer false alarms, which has been the problem with many sepsis screening projects in the past, where 5 or 10% get screened positive, and then physicians stop wanting to do the screening process. So all told, somewhere between 1 and 2%, probably 1.5 to 2% will screen positive, which seems to be a very reasonable number to go on to have the confirmation step. Next slide. So our clinical pearls are all members of the clinical team should maintain high index of suspicion and embrace non-hierarchical communications regarding the status of your patient, and so as not to miss a case of sepsis. We also encourage all members to speak up and know that their input is valued by the care team. Next slide. I'd like to turn this over to Dr. Olvera to talk about assessment and treatment. Thank you, Lori.
Thank you, Dr. Main. So I'm going to be going over assessments and treatment care bundles. Next slide. These are actually the key principles for assessment and treatment. Number 1 and number 2 are actually saying the same thing. We really want to avoid delays, act quickly upon recognition of sepsis and minimizing that time to treatment. So when a patient is septic, we don't want to hold treatment and continue to observe for several hours. Treatment begins immediately. And to assist with minimizing treatments, you can develop protocols and standardized OB order sets that can be implemented by the MD once a patient screens positive with sepsis. And this not only incorporates best practice, but it actually minimizes the time and discussion over treatment options. You're going to want to monitor closely for response to or lack of response to interventions. For example, an elevated lactate, you're going to want to trend that lactate and make sure it's trending down in response to fluids. For communicating sepsis, a great handoff is important. A recommendation is to develop checklists around sepsis for your handoffs. Next slide. So sepsis, a diagnosis of sepsis is actually sepsis screen positive with end organ injury. And this is the recommended treatment per the Surviving Sepsis guidelines, is that we want to begin source-directed antibiotics if they're not already started. And if your source is unclear, you want to go more to a broad spectrum antibiotics that can be achieved by 1 or 2 antibiotics that covers the gram-positive, gram-negative, and anaerobes. You're going to want to increase your fluids to 30 mils per kg fluid, 30 mils per kg within 3 hours. And you're going to want to draw your lactate and trend your lactate until it's less than 2. Blood culture should be drawn immediately, if not already drawn, and you're certainly going to want to involve the RRT to escalate care as needed. Next slide. So these are the recommendations for monitoring. Fetal monitoring is, continuous, because these women are capable of vascular collapse, so you're going to want to be able to monitor the baby continuously during that time. Pulse oximetry is valuable. It should be continuous, so you could be monitoring for that sustained tachycardia in response to treatment, as well as picking up if a patient is desatting, which could be evident if she rapidly deteriorates. Blood pressure and temperature are every 30 minutes, and it's really important to increase the frequency and surveillance, so every 30 minutes while the patient is presenting with an organ injury or till the vital signs normalize. And of course, the urinary output should be monitored every hour, as well as the mental status should be monitored ongoing. Next slide. Okay, so for blood cultures, bacteria from the pelvic region is polymicrobial, so genital tract cultures are rarely performed, as it just reflects contaminated organisms, and patients with choreo generally have a negative blood culture, so it will be up to the provider and depend upon the clinical situation as to whether blood cultures are collected initially when the patient screens positive for sepsis or when sepsis is confirmed. And certainly if a patient is showing end organ injury or septic shock, you draw those blood cultures immediately. Next slide. Blood cultures, should be collected in suspected sepsis and septic shock. We always do 2 cultures, and the likelihood of that organism being the culprit is identified if you see it in both specimens. Next slide. Fluid management is really important because septic patients are intravascularly dry, and the treatment is always to restore the volume. And so your initial resuscitation should include a 30 ml per kg fluid bolus. And in the past, we used to just give several liters of fluid blindly, but now the 2016 guidelines are very clear that following that initial fluid resuscitation, that additional fluid should be guided by frequent reassessment of hemodynamic status. You can do this in a couple of ways, either by an MD performing that perfusion assessment, or you can use a technology of NICOM, or a non-invasive cardiac output monitor. And NICOM actually attests the fluid responsiveness by measuring the stroke volume index in response to a fluid challenge that you can either do by passive leg raising or by a fluid bolus. And fluid responders will always increase their cardiac output, while patients who are not fluid responsive will have a decrease in cardiac output. Always use your RRT. They can perform this test for you. Next slide is, when do we escalate care? Assessing and treating the septic patient, it's important to know when do we need to give more care. And these patients present with signs of sepsis anywhere in the hospital, and they have the ability to rapidly deteriorate. So therefore, escalating the care by getting the charge nurse and the MD to the bedside are for these following conditions. Is hypotension with your MAP less than 65 despite that fluid bolus, persistent hypoxia, and altered mental status. Next slide. I can't say enough about the rapid response team. They are there to support the areas outside of the intensive care. They can help with assessment of a deteriorating patient. They can provide, interventions, they also are there to do assessments and collaborate with the OB nurse. Next slide. Escalation of care should be a multidisciplinary approach, and so decisions as to the best location for the patient and treatment modalities can be decided by the team. So it's important not to delay transport of a critically ill pregnant patient because of the inability to monitor the fetus. Just remember that if you stabilize the mother, you're going to stabilize the fetus. Next slide. Some of the considerations additional considerations. The purpose, of vasopressors is to constrict that pathologically dilated systemic circulation and maintain perfusion, and the current guidelines recommend norepinephrine. However, if the patient is not responding to the norepinephrine, you can add an inotrope, and dobutamine is great because it increases the MAP and cardiac output. And then you're going to want to avoid hyperglycemia, and so 180 is your mark. So these women, you should be at least doing a point of care testing to make sure that they don't have hyperglycemia. Maternal temperature control is important. Use of acetaminophen and cooling blankets. You can consider giving steroids for fetal lung maturity and using SCDs for DVT prevention in these septic patients. Next slide. Great. I'm going to turn it back over to Dr. Main.
I have to unmute. No, go ahead. Thank you, Lori. Go ahead. Next slide. The key principles for antibiotics and source control are illustrated here. One is that antibiotics should be started early, ideally with 1 hour of presentation, which is critically important for sepsis. The initial choice of antibiotics is in critically ill patients is empiric and broad spectrum to cover most or all likely pathogens. Source control, which is a term used for treatment of abscesses or internal sources of infection, such as intrauterine infections or soft tissue infection, should be initiated also in a timely fashion with the least invasive approach possible. Next slide. As culture information becomes available, the choice of antibiotics will change and ideally narrowed if possible. However, since most pelvic infections are polymicrobial, it may not change the choice of antibiotics completely. Next slide. How you should refer to your local antibiogram for your choice of antibiotics and the likelihood of resistance. And take into account that if the patient's been recently hospitalized, she's at high risk for MRSA and other organisms that have multi-drug resistance. We really strongly recommend the use of sepsis order sets to expedite the process of antibiotics. Next slide. In the toolkit, we gave multiple tables regarding antibiotics, and they're there for your use in developing the sepsis order sets. Necrotizing fasciitis is a very important infection, and we've had several maternal deaths from necrotizing fasciitis. And it is diagnosed clinically in the presence of fever, pain out of proportion to the exam, bullae erythema, and rapid progression of the findings. This is an emergency and really needs surgical management. So this is something that should be suspected and examined for. Next slide. We've developed in the toolkit antibiotic regimens by each condition. And again, there's notes and durations as well as the choices recommended from national sources. Next slide. Here's an overview of the types of antibiotics recommended for either abdominal infections, chorioamnionitis, pneumonia, endometritis, hospital-acquired pneumonia, and soft tissue infections, UTI. This is one of the challenges with sepsis, is that it can be caused by many different sources, as Christa pointed out in the opening slides, and so we have to have a broad range of choices here for us to build our order sets. Next slide. If a patient has no improvement with the initial fluid resuscitation and the antibiotics, that's when you start looking for additional or underlying or hidden sources, i.e. sources of infection that might be amenable to percutaneous drainage. This is only done typically in consultation with interventional radiology and consultation with infectious disease. Next slide. Patients with identified source of infection requiring surgery, this is also a place for a consultation with the gynecological surgeon, of course, like we all are trained in DNC or hysterectomy, and then looking for possibilities of drainage. If you're talking outside the genital tract, then that's a general surgeon, for such as drainage of abdominal abscesses, appendectomy, or cholecystectomy, or drainage from gallbladder bed, or necrotizing fasciitis debridement. And again, early consultation is really important in this setting where there's the potential for surgical intervention. Next slide. So now I'm going to go into obstetric considerations. Next slide. The timing of delivery in a pregnant woman who is septic needs to be individualized, taking into consideration just how close to term she is, and the overall maternal and baby status, fetus status. How's the heart rate doing? Is it responding to maternal treatments like fluid and antibiotics and temperature control? Ideally, we wouldn't necessarily do a delivery for a preterm gestation. We wouldn't do a delivery unless there's an infection in the genital tract. And we wouldn't do a delivery based on an infection outside the genital tract, like pyelonephritis, unless the mother had very severe infection, i.e. sepsis, that was not responding. The role of neuroaxial procedures, i.e. epidural or spinal for C-section, needs to be individualized, and it depends on how severe the infection is. And in the setting of chorioamnionitis, most anesthesia societies recommend that it's okay for spinal or epidural. But in the setting of septic shock, it may be preferred to go with a general anesthetic. Next slide. This again is emphasizing the need for individualization of the timing of delivery. And that cesarean delivery is generally reserved for the obstetric indication rather than an infection itself. Also of note, if we're dealing with a preterm gestation and there's felt to be time for 24 or 48 hours of corticosteroids, they are not contraindicated in this setting. Next slide. As noted before, in the setting of full sepsis and particularly septic shock, we strongly consider avoiding neuroaxial procedures, which is different than our approach for patients with infection like chorioamnionitis. And this is largely because the physiological status of the patient with sepsis or septic shock is compromised and may not do well with the volume constriction noted, the volume changes noted with neuroaxial procedures. Next slide. I'm going to turn it over to Christa Sakowski for discharge education.
Next slide. So key principles of discharge education. In the case reviews, they found that women received some education as far as infection on discharge, but there was no support person present. And so when she started to develop signs and symptoms, basically said that she felt too ill to even go to see her physician for follow-up. And there was a cascade that started prior to the patient even being seen. So the recommendation is that every woman receive discharge education regarding some danger signs along with a support person prior to discharge. Instructions at every point of care should include ways to decrease their infection risk, such as frequent hand washing. And for women who have had sepsis, planned follow-up contact should be made within 3 to 4 days after discharge. Next slide. A key clinical Pearl summary that will comprise the whole entire presentation and toolkit are that prompt recognition and rapid treatment of maternal sepsis improves outcomes. So if we haven't sold that to you at this point, we haven't done our job. None of the current systems perform satisfactorily in pregnant women, as they have a low detection rate or low sensitivity, or a high false positive or false alarms. And I think we've all lived through that with our previous systems. With suspected infection, a MAP of less than 65 is sufficient to initiate the sepsis protocol. Sepsis screening criteria are not met. CMQCC recommends a new two-step approach to diagnosis of maternal sepsis. A screen is considered positive if 2 or more values meet the criteria listed. Heart rate and respiratory rate are sustained for 15 minutes. If there is a concern with the patient's clinical status and suspected infection, it may be sufficient to proceed to step 2 for further evaluation. So basically what this is saying is that if there's a feeling and there's symptoms that the patient seems off, not to be bound by the clinical steps in this process. So if you really feel that something's off and we're not quite meeting criteria, go ahead and proceed to step 2. Next slide. The two-step approach promotes fewer missed cases or higher sensitivity and fewer false alarms. The two-step approach estimates that only 2% of patients will screen positive. Early administration of antibiotics is critically important in sepsis, ideally within 1 hour of presentation. The initial choice of antibiotics in critically ill patients is generally empiric and broad spectrum to cover most or all likely pathogens. Assessment for source control, such as surgical or percutaneous drainage or debridement, should be initiated in a timely fashion and using the least invasive approach possible. Next slide. I'm going to turn it over to Lori for this presentation.
Thank you, Christa. So I get the best part is to present the case. This is actually a 26-year-old. She's G2P1. She was on high-risk maternity and hospitalized for preterm rupture of membranes at 32 weeks. So the first 7 days was uneventful, and on day 8 was when she started feeling warm and her heart was racing. So the nurse did the vital signs and noticed the temp was 97.8, which is normal. Heart rate was 130. So she had tachycardia. The respiratory rate was 22, and her blood pressure was normal, 115/62, and was having some fetal tachycardia at 160 per minute. The patient was contracting every three minutes, and the cervical exam was done. She was 380 and -1, which this was unchanged for her. Next slide. Her WBCs was 22,000, and she was actually creeping up in her WBCs over that 8-day period. Patient screened positive, but there was no sepsis confirmation performed, as there was no evidence of fever or clear source of infection noted at that time. The elevated WBCs was attributed to the betamethasone that was given 4 days prior. So they just felt like it was normally elevating in response to the beta. And then what happened is the baby started getting late D cells, minimal variability, and the decision was made that we needed to go back for a repeat cesarean. So 2 hours later, she had that C-section, and next slide. When the infant APGARs were 1 and 8, and the baby actually went to the NICU, and in the recovery room was when the patient started kind of showing that she was in septic shock. The temperature was 101.8, the heart rate was 120, and the BP was 88/40 with a MAP of 56. And the respiratory rate, she was tachypneic at 36. Called the RRT, she definitely just rapidly deteriorated, hitting the PACU. So the IV fluids were started. We were giving 30 mils per kick fluid bolus. We're starting a very broad spectrum antibiotic of Zosyn because the source was unknown. And then the lab started resulting, and the lactate was 9. And then her urine output was very diminished, and she was having 10 mils per hour. Next slide. Patient was noted to be bleeding at the incisional side, so we're wondering if she was going into DIC. So the decision was made, let's just get her up to ICU. Let's stabilize. So she was stabilized up in ICU with supportive care, given more fluids and given broad spectrum antibiotics. And the final diagnosis was septic shock due to chorioamnitis with bacteremia of group B strep and E. coli. And actually, these are, these are the bacteria that is most identified in pregnant women, or I should just say perinatal women in general, along with strep A. But these are very common bacteria in septic patients. And next slide. So some of the lessons learned, is the no fever. It was believed, or the sepsis wasn't confirmed because there was a belief that she didn't have a fever, so she can't be septic. Have to mention that, in reviewing like mortality and morbidity reports, that some of those patients actually went through a whole hospitalization without ever developing a fever. So so fever does not ever have to be present in order for a patient to screen in positive, and that's what caused a delay here. With the lack of the sepsis confirmation testing, there was missed opportunities for earlier treatment with fluids and broad spectrum antibiotics. And so when she actually screened in, when she had the heart rate and the WBCs are what screened her in, and that's where treatment should have begun to avoid the progression to septic shock. And then, of course, the last was the elevated white blood cell count was kind of explained away because the belief that she had the beta, so it was just elevating the white count. And to close, I just want to give a great statement. In the earlier stages of sepsis, just remember it's harder to recognize that we need to intervene. However, remember, it's easier to treat. If we wait till later, then it's easier to recognize because they're in vascular collapse, and in this case, but it's difficult to treat, and the morbidity and mortality is increased at that point. Next slide. So here
Before
are the
we leave
appendices.
that, Lori, I'd just like to make a statement or two. In our reviews of maternal deaths, a theme that's been present throughout the hemorrhage cases, the hypertensive cases, and our sepsis cases has been denial and delay. And those are present in many of our sepsis cases. And in this case presented here is that folks found reasons to disbelieve that she had sepsis, even though she obviously had preterm ruptured membranes and had a high pulse and now was in labor. That says chorioamnitis to many people, but people sometimes will go out of their way to disbelieve what they're seeing in front of them. So denial and delay and dismissal are the 3 deadly Ds that you got to remember in all these cases, including sepsis. Go ahead.
That's great. So in this, there's in the toolkit, you're going to see these are the appendices that you'll find in the toolkit. Next slide. And we want to thank you for joining the webinar. And the toolkit will be on the website. And so now we're going to open it up to questions, and I'm turning it over to Valerie.
Thank you, Lori. We do have several questions. I have a couple for Elliott to address. Is sepsis largely driven by C-sections? And do we have data that shows regional trends in sepsis?
So sepsis is diagnosed more often after surgical procedures, including C-section, but sometimes the reason that you're doing the C-section is because the patient has a bad infection. So there is a relationship, but it's certainly sometimes it's cause, sometimes it's effect. But any surgical procedure, particularly in the setting of a non-clean site, which is what the genital trachea is during labor with ruptured membranes, is going to put you at risk of infection and therefore risk of sepsis if it's delayed. We don't have really good regional data on sepsis, partly because of the non-standard definitions that have been used, which in turn is reflected in ICD-9 codes. What we've seen in California data is that in places that use the older version of the CMS criteria for sepsis and apply that directly to pregnant women, will have rates of sepsis 2 or 3 times higher than places that use the criteria regarding end organ injury for sepsis, formerly known as severe sepsis. So it does matter what your diagnostic criteria are in terms of how your coding works, and therefore how it's assessed in administrative data. Someone needs to mute their phone if they're going to use some kind of power tool. Okay, next, Valerie.
So the next question, there's a couple nursing questions for Lori and Christa. How long do you take to have the leuko count ready? And is the 30 milliliter bolus given over 3 hours?
What was the first question?
How long do you take to have the leuko count ready?
So I think she's asking about the WBC. Generally, we look at that as available. We take the last one that's available. So if it was done on admission, that's okay. Otherwise, you'd have to draw a new one if it's beyond 24 hours. And in your hospital, Lori, how long does it take to get your WC back?
How long does it take to get back? 45 minutes.
Yep. So it should be, that's a pretty reasonable hour to run a CBC.
And so, the 30 mils per kg fluid bolus is generally based on a clinical condition, but you generally give, you can give each liter over an hour, or if your patient is hypotensive, you're going to want to give it rapidly.
Okay, and there was a couple of questions about giving steroids for lung maturity in sepsis, and the steroids can flare up in the infection, so what is recommended?
First of all, you have to make the judgment as to whether the patient is likely to be pregnant and still pregnant in 24 hours. There is benefit for 24 hours of steroids. It doesn't have to be 48 hours, and it depends on the severity. Most patients are not going to get steroids in the setting of infection. In the setting of sepsis, that's really even less likely, unless it is an infection outside the genital tract. And we see this commonly preterm with pyelonephritis. So that is something that will be treated and the pregnancy will go on. I don't rush to give steroids with pyelo unless I really do think she may be delivered. But that is classically the setting in which you would consider it. Most pyelos can be treated and the pregnancy can go forward.
There's 2 questions about fetal heart rates and as part of the initial criteria for assessing maternal sepsis, and the question is, should they no longer be using that as one of the criteria?
I can answer that. There's really no studies that substantiate the use of fetal tachycardia, but I know that some of the hospitals actually put it on their criteria because kind of pulling it from the chorioamnitis of having fetal tachycardia. So it really wasn't substantiated by evidence, but they just used it part of the criteria. So recommendation is not to use the fetal tachycardia as part of the criteria. We have the criteria here for you that is validated for you.
So that's, again, a different setting than diagnosing chorio, in which that is part of the CDC criteria. We're talking about sepsis here, and so it's not in the criteria for sepsis, but it still can be used in other ways. You know, the deal with fetal tachycardia is that it's tightly related to maternal temp. So it's kind of a twofer. If you have a maternal temp, a high temperature, you're likely to have a high fetal pulse rate. So we were looking for other factors besides that one to look for in that. And in addition, that we're looking for MUs, which are available in vital signs, and the fetal heart rate is often in a different system than the maternal vital signs. So this is looking at maternal vital signs and white cell count.
Okay. The next question is, what is the lower limit of normal for UOP postpartum with normal diuresis? We have found a reference that suggests 1.0 milliliters per kg as a lower limit. And there's lots of questions about fluid resuscitation based on the weight of the pre-pregnancy weight and how the fluid affects lactate results. Lori, do you want to address some of that?
Yes. Well, so the fluids, we want to give the 30 mils, the 30 mils per kg fluid bolus, and not really, and really go with that bolus. If we have a higher lactate, we really want to just address it. So often, I can tell you clinically what I see is that we have a high lactate and either people don't feel comfortable with the fluid bolus, they give a 500, it really doesn't affect the lactate, and it just actually delays the patient getting treatment. So it's, you know, in the instances when it's indicated to give the 30 mils per kg fluid bolus, meaning when they have a diagnosis of sepsis, is just to give that because it really affects the lactate, and you can look at the response, you know, because the response, you're looking for the response, but the response to treatment needs to begin with giving the adequate treatment. And then, you know, the lactate should trend down with the fluid bolus or over time. Is that?
So the part of the question is which weight to use.
Which weight?
The issue is, whether you use a pre-pregnancy weight or the current weight. I would just go with the current weight.
Current weight, yeah.
Done with it.
Yeah.
Trying to estimate the back weight.
Oh, no, yes, definitely.
And I think, Laura, you would expect to see a start in the fall of lactate after 2 hours or so, or maybe even a little sooner.
Even sooner, you know, even sooner. But generally by 2 to 3 hours, and that's why they recommend to trend the lactate every 3 hours so you can monitor that response. So yeah, you're right with 2 hours is good.
And then how long after labor can you expect lactic acid to return back to baseline levels?
Well,
we don't have perfect data on that.
Yeah, we don't.
You know, you certainly, some people don't get a rise in their lactate during labor, but some people get a pretty significant rise, 2 to 4 to 5. I think there's data suggesting that it does fall fairly rapidly within an hour or two, or start to fall. But it's not a uniform issue. A uniform pattern.
That's exactly it.
So there's a couple questions on screening when women come into the hospital, and also then on like if there's a standardized screening tool, and what gestational age do you recommend using the OB second step criteria?
Well, it can be screened for any pregnant woman, first, second trimester, as well as third and fourth trimester, i.e. postpartum, because, sepsis can occur anytime along there. So we feel that it's something in the patients that were tested did include early gestation and some postpartum ER cases that were in that 15,000 population. There's a question I see on the screen about 2% positive. That's 2% positive in the first step of the two-step process. So yes, if you just had a one-step process, it would have a false positive of 2%. But with the two-step, with the confirmation step, the overall false positive is very, very low.
Okay, let's see what else we need to answer here. If the patient has suspected chorio and antibiotics have been started, but the blood cultures haven't been done, and later it is determined the patient has sepsis, will the patient fall out of compliance with the sepsis bundles?
No, I'll answer it. No, they won't, because the guidelines are is measuring from when they have a diagnosis of sepsis. So it's two parts. So it's go ahead and draw those blood cultures, and generally speaking, it's the recommendation is prior to antibiotics, but it's not exclusive. Meaning, sometimes the patients start out initially just have an infection, and then they progress into sepsis, and that's when the guidelines are really strong that you have to draw blood cultures at that time. The other part of it is the question, if I do blood cultures after we started antibiotics, is it going to be valued? Yes, it will be, because it's going to be able to identify any bacteria that's not being covered by the antibiotics the patient's presently on. So it's always, oh, go ahead.
No, we spent a lot of time on this and carefully parsed the CMS criteria. And it is, I want to underscore, this is exactly what Lori said, is that you can be giving antibiotics for chorio, for example, and then if you develop sepsis or septic shock after that, and you haven't done a blood culture up to that point, do it then, and you have absolutely met the CMS criteria for treatment of sepsis.
Okay.
But that's also important. That's also important, I would like to add, that, and maybe we didn't stress enough, that it is important to treat the infection early, like chorio. So I would not hesitate to treat chorio even if we haven't diagnosed sepsis yet. Go ahead.
There's a question about which IV fluid is best to use for the bolus.
It's just a crystalloid. There's no, the guidelines say crystalloid. And so you can do LR or normal saline. They don't distinguish between the two anymore. Initially, the old way of thinking was normal saline, but in the 2016 guidelines, they just said a crystalloid. It can be LR or normal saline.
There's a question about changing critical lactate values from 4 to 2 due to the volume of calls when it was 2. Do you think this would be an adverse change for our pregnant and postpartum patients?
Lori, go ahead.
You're saying if the lactate is
they're changing it from 4 to 2.
Mm-hmm.
Or from 2 to 4, I think, is probably what they're talking about. So that the critical value.
Oh yes, you're correct. From 2 to 4 from 2.
Yeah. So too many, quote, false positives at 2. So they, in their setting, they were changing it to 4. You know, I think that you do get false positives in labor for the reasons we're talking about. That's why it's not in the, you know, patients in labor or immediately delivered by first hour. It shouldn't be used as a criteria. But if you're not in labor, like a pyelonephritis patient, it would be a reasonable criteria. I'm not sure I've seen any reason not to use 2 in pyelo.
Yeah, correct. This, you know, the studies that have been done will validate that we still should be treating those non-laboring patients with a criteria of 2 until there's further studies done. But no, we go by the adult criteria of 2.
Well, I thank everyone for submitting their questions. We have several that we weren't able to address during the time, but we will capture those. And I would recommend that many of the questions that were asked, the information is covered in the toolkit. And so we encourage you to download that toolkit and read through it and see what you can do to help improve the care for women at your facilities. I want to thank our panelists, Elliott, Lori, and Christa, and thank all of you for joining us today. Thank you very much. Have a good afternoon.
Good afternoon, everyone.
Bye, everyone.
Good afternoon. Bye-bye.